So next important competency, we have now completed the boundaries of the content of the inguinal canal, and we have seen some of the protective reflex innate mechanism present in our body to prevent the inguinal hernia because it is a site of an anatomical weakness. Let us jump into one of the important thing called Hasselbalch triangle. Right, now look at this picture carefully here. You can see this muscle, this tight muscle present here called rectus abdominis muscle. Right, and we have the external iliac artery and the vein present there, and we have the inferior epigastric artery running laterally. You can see the artery running here. You can see that. Okay, and the base will be by the inguinal ligament. Okay, so let me talk through the boundaries of the Hasselbalch triangle, and I will discuss what is its importance. Okay, so the boundaries of the Hasselbalch triangle are medially by the lateral border of rectus abdominis muscle, laterally by the inferior epigastric artery and the vein, and the floor by the canal and the inguinal ligament. So this forms a beautiful Hasselbalch triangle. Right, now once again look at this picture here. Where is now? So I told you the boundaries of the Hasselbalch triangle, right, and I told you the lateral boundary will be by the inferior epigastric artery. Now look at both the rings present. The superficial ring is present here. The deep ring is present here. Now go through one fact here. The deep inguinal ring is present laterally to the inferior epigastric artery. I'll write this point here. The deep inguinal ring is present laterally to inferior epigastric artery. Clear? So this forms a very basic anatomy where the indirect and the direct hernia comes. Okay, so when I talk about the direct hernia and I talk about the indirect hernia, I always talk in relation with the inferior epigastric artery. Clear? So this inferior epigastric artery forms an important relation of the lateral border of the rectus abdominis muscle because the direct inguinal hernia comes through the Hasselbalch triangle and the indirect inguinal hernia comes laterally to the, this is indirect inguinal hernia, comes laterally to the inferior epigastric artery. So we will go to that later. Okay, so the boundaries of Hasselbalch triangle are medially by the lateral border of rectus sheath and abdominis muscle, laterally by the inferior epigastric artery, below by the inguinal ligament. Okay, so this forms the boundaries of the Hasselbalch triangle, and the direct inguinal hernia. Okay, direct inguinal hernia comes through the Hasselbalch triangle, and the indirect hernia comes laterally to the inferior epigastric artery through the deep inguinal ring. Clear? So now look at this picture here. So this is the inferior epigastric vessel. Okay, so what comes medial to the inferior epigastric vessel will be the direct hernia, inguinal hernia, and what comes laterally to the inferior epigastric artery will be the indirect inguinal hernia. Clear? So one artery is going to divide whether the hernia will be direct or not. So this direct hernia will come through this triangle called Hasselbalch triangle, and the indirect hernia comes through lateral to the inferior epigastric artery. Let us go into the next competency in 44.5, anatomical basis of inguinal hernia. First of all, what is an hernia? It is a protrusion of the abdominal content beyond the normal confines of the abdominal wall. Okay, so it is a protrusion of the abdominal content beyond the normal confines of the abdominal wall. So there are three parts of any hernia. First, the sac. Second, the content of the sac. It can be a small gut or large gut. And third, coverings of the sac. Okay, so the sac, the content of the sac, and the coverings of the sac. As I told you, the inguinal hernia are broadly divided into a direct hernia and an indirect hernia. Right? So let us go into what is a direct hernia and what is an indirect hernia, and let us once again read in depth of what is happening. A direct hernia is because of weak abdominal muscles. A direct hernia is because of weak abdominal muscles, and indirect hernia is predominantly congenital. A direct hernia happens because I told you it's a weak abdominal muscle. It is because of chronic cigarette smoking, because of pendulous abdomen, or because of chronic coughing in case of an COPD patients, in case of a bronchial asthma patient. Okay, so because of that, the abdomen muscles become weak, they become pendulous and soft, and the tensile strength will be much weaker. So because of that, the protrusion happens through the abdominal wall. So that is a direct hernia through the Hasselbalch triangle. So the indirect hernia is congenital. It happens in young men, and it comes from the deep inguinal ring to the superficial inguinal ring. So let us jump into the in-depth of the difference between indirect and the direct hernia. A clinical scenario, question type may come like this. A 60-year-old man who is a known patient of COPD has developed swelling in his scrotum for past 6 months. On examination, the swelling is abdomen and it goes up to the scrotum. The swelling is reducible. Okay, so what is the type of hernia we are talking about, and discuss the parts of the hernia. Okay, discuss the anatomy behind it. Okay, so we have to know what is a direct hernia, what is an indirect hernia. Okay, and I told you, regarding the boundaries called the Hasselbalch triangle. With that, how are we going to divide a direct hernia and indirect hernia, right? So once again, let us dig into that. An indirect hernia enters into the deep ring. Okay, I will draw the picture here. We have the deep ring and we have the superficial inguinal ring. The indirect hernia enters through the deep ring and traverses through the canal and enters the superficial inguinal ring, while the direct hernia enters through the Hasselbalch triangle, which is present here. Okay, Hasselbalch triangle. So the neck of the sac is lateral to inferior epigastric artery. I told you, we have an artery called inferior epigastric artery. Medial to it will be the direct hernia, lateral to it will be the indirect hernia. Okay, here the neck of the sac is medial to inferior epigastric artery. So it is directed downwards, forwards and medially. Because it travels through the canal, the direction of the canal is downwards, forwards and medially. So the direction will be downwards, forwards and medially. The direction of direct hernia will be downwards and straight. Indirect, very commonly unilateral, but direct, because of abdominal weakness, abdominal muscle, it is bilateral. Indirect, it occurs in young people, and for direct, it is old people, common. And indirect, it is congenital. For direct, it is acquired because of weakness of anterior abdominal wall in case of a chronic smoker, chronic cougher, or a pendulous abdomen. Okay, so look at this match here, and there are two important points I like to take from this slide here. An indirect hernia traverses from the deep ring to the superficial ring, and the hernia, the content there, is lateral to the inferior epigastric artery. When you talk about the direct, it travels in the Hasselbalch triangle medial to the inferior epigastric artery. So these two are the basic anatomical difference which will make through what is an indirect and what is a direct hernia. Okay, so the most common hernia in elderly will be the direct hernia because it is acquired, and the most common hernia in children will be the indirect hernia, indirect inguinal hernia. And this is congenital, very commonly congenital. And in female, most common inguinal hernia is indirect, is more common than the direct hernia. So beyond that, there are also other terminologies you should know about hernia. Sometimes the hernia is, many of the times the hernia is reducible in case of a direct, where the content of the hernial sac can be returned to its normal position in the abdomen. This is the reducible hernia which is common in direct hernia. Sometimes hernia can go incarcerated, where the contents are entrapped in the groin. Okay, so that the content cannot come out to the abdominal cavity. Okay, it is entrapped in the groin. That is called incarcerated hernia. Sometimes hernia can be strangulated, where the contents are ischemic because of vascular occlusion, and this is a surgical emergency which you have to treat, or else there will be ischemia, necrosis, and even gangrene of the bowel. Okay, so now let us dig into the question-based discussion of the topic. As I told you earlier, right, right? The very purpose of the class is to make sure to strengthen you the basics of the particular topic and to give you certain questions and to understand more what is happening in the topic, right? So overall, I discuss about the boundary, first of all, the extension of the canal, which is downwards, forwards and medially. The length of the canal, 4 centimeter. The extension starts from the superficial inguinal ring to the deep inguinal ring. I told you what is a superficial inguinal ring. It is a triangular deficit formed in the aponeurosis of external oblique muscle, and the deep inguinal ring, it is a oval deficit formed in the fascia transveralis. So as we talk through the boundaries of the inguinal canal, we came across the inguinal canal has got a roof, a floor, an anterior wall and the posterior wall. The anterior wall of the inguinal canal is formed by the skin, the superficial fascia, the external oblique aponeurosis, and the medial half by the internal oblique muscle. The posterior wall is formed by fascia transveralis throughout, and over the medial 2/3 of the posterior wall is formed by the conjoint tendon by the internal oblique muscle and the transverse abdominis muscle. The roof once again is formed by the arched fibers of internal oblique and the transverse abdominis muscle, and the floor is formed by the inguinal ligament, and of course the extension of the inguinal ligament called the lacunar ligament. So this is the boundaries of the inguinal canal, and we talked about the content of the inguinal canal. For males, the complete content will be spermatic cord, and for females, round ligament of uterus. The partial content will be the ilioinguinal nerve. And when you talk through the content of the spermatic cord, which include the vas deferens, 3 arteries, artery to testis, artery to vas, cremasteric artery, pampiniform plexus of veins, genital branch of genitofemoral nerve, lymphatics, and the remains of process vaginalis. So these are the contents, very important when we talk about the inguinal canal. And there are some protective mechanisms present to make sure that the herniation do not take place. That includes a lot of mechanism like shutter valve mechanism, flap valve mechanism, ball valve mechanism, and slit valve mechanism. And I have detailed through muscle will act and which will prevent the herniation. Clear? So ultimately, the superficial ring and the deep ring should be protected. Okay. So the external oblique muscle, the internal oblique muscle, and of course the other fibers protect these openings to make sure that the herniation do not take place. Clear? And we have come through some important anatomical structure called Hasselbalch triangle, and in that Hasselbalch triangle, I told you the very important landmark will be the inferior epigastric artery. The medial boundary will be the rectus abdominis muscle and base by the inguinal ligament. So why this Hasselbalch triangle is important? Because this is the one which is going to anatomically divide the hernia into a direct type and an indirect type. A direct type comes through the Hasselbalch triangle medial to the inferior epigastric artery, while the indirect inguinal hernia comes through the deep inguinal ring, traverses the canal and enters the superficial inguinal ring, and it is lateral to inferior epigastric artery. Okay, so these are the consolidated points which you should remember, and let us now jump into the question-based discussion of the topic. So let us go into the first question. The conjoint tendon is formed by A. External oblique and internal oblique, B. Internal oblique and the transverse abdominis muscle, C. External oblique and transverse abdominis muscle, D. All the above. Okay, so the conjoint tendon is formed by the B choice, internal oblique and the transverse abdominis muscle. Okay, so the internal oblique and transverse abdominis muscle forms the arched fibers, okay, over the roof of the inguinal canal. This will strengthen the abdominal wall in the posterior wall of the inguinal canal. Clear? So it forms the arched fiber between the transverse abdominis and the internal oblique muscle. Right? All are true about the inguinal canal except A. The conjoint tendon forms a part of posterior wall. Yes, the conjoint tendon or the medial half of medial 2/3 of the inguinal ligament, the medial 2/3 of the inguinal canal over the posterior wall, it is contributed by the conjoint tendon. B choice. Superficial ring is formed in external oblique aponeurosis. Yes, that is also true. Okay, the superficial inguinal ring is formed by the triangular deficit created by the external oblique aponeurosis as it attaches to the pubic crest. The deep ring is formed in transverse abdominis muscle. Is it right or wrong? The deep ring is not formed in transverse abdominis muscle. It is a defect, a oval defect seen in fascia transveralis. Okay, it is a oval defect seen in fascia transveralis. This defect is present 1.25 centimeter above the mid-inguinal point. Okay, so this is the anterior superior iliac spine, and this is the pubic tubercle. This is the inguinal ligament. Okay, this is the mid-inguinal point, and over the mid-inguinal point, 1.25 centimeter above the mid-inguinal point, we have a oval deficit formed by the fascia transveralis, and that creates the deep inguinal ring. D choice. Internal oblique forms both anterior and the posterior wall. Absolutely true. The internal oblique not only forms the anterior and the posterior wall, it also forms the roof. Clear? So the clear answer, the false statement here is deep ring is formed in transverse abdominis. Let's go to the next question. Which of the option is not true about inguinal canal? So we are going to decode which is false here. First of all, A. So there are 5 options present there. A. It is an intermuscular canal. As I taught you, the inguinal canal is a musculo-aponeurotic canal. Okay. So one thing is formed in the musculo-aponeurotic part. Clear? That is by the external oblique muscle. And other deficit is formed in the fascia, by the fascia transveralis. Okay. Let us keep this option there. Second, the superficial inguinal ring is situated superior and lateral to the pubic crest. That is also true. The superficial inguinal ring is situated superior. Let me draw the pubic symphysis here. We have the pubic crest here, and we have the triangular deficit present there. Okay. So it is superior and lateral to the pubic crest. So this is a medial crura, and this is the lateral crura. Okay, so it is superior lateral, that statement is right. Third, the deep ring is supromedial attached to rectus abdominis muscle. The deep ring has got no relation with the rectus abdominis muscle. It is a deficit formed by a oval deficit formed in the fascia transveralis. Okay, so this has got no relation with the rectus abdominis muscle. Even when we studied Hasselbalch triangle, we can see how the rectus abdominis forms a medial relationship of the Hasselbalch and laterally by the inferior epigastric artery, and the deep ring will be present still more laterally. The internal oblique, D choice, internal oblique forms both the anterior and the posterior wall. Yes, that is true. Even the previous question, the same statement has been there. Internal oblique not only forms the anterior and the posterior wall, it also forms the roof of the inguinal canal. 5. The cremasteric artery is a branch of external iliac artery. The cremasteric artery is not a branch of external iliac artery. It is a branch of inferior epigastric artery. Okay, it's not a branch of external iliac. So this statement is false. This statement is false. So C and E are false statement here. So A is an intermuscular canal. So even though it is not a strict definition, but still I can accept that it is an intermuscular canal. So superficial ring is situated superior and lateral. That is also true. But C choice is wrong. It is supromedial attached to rectus abdominis. So it is wrong. It is no related to rectus abdominis muscle. And cremasteric artery is definitely not a branch of external iliac artery. Right. Next question. And we have selected these questions, which has been asked recently over the past 5 or 6 years. And we have also refined the question to make sure that it covers the entirety of the topic. Okay. So all the following structures pass through the inguinal canal in female except, okay, we are talking about the content of inguinal canal in female. Okay. So when I taught you, remember, I told you one thing, no? Inguinal canal, the content in male is a spermatic cord that forms a complete content, and in female, the round ligament of uterus forms the complete content. Okay. But here, the partial content is also that the ilioinguinal nerve is a partial content. Okay. So now, if you look through this, the options there, A, ilioinguinal nerve. Yes, the question says it's passed through the canal, whether they're not asking whether it passed completely or no, or partially. Round ligament of uterus is a content. Lymphatics, of course, will be there. Inferior epigastric artery is not a content of the inguinal canal. Okay, inferior epigastric artery is an odd man out there. Next question, following pass through the deep inguinal ring except. Now please apply whatever I told you to the what is called a complete content and what is called a partial content. Okay, spermatic cord is a complete content. When I talk about complete content, it extends from the deep inguinal ring to the superficial inguinal ring or vice versa. Spermatic, internal spermatic fascia, it's a covering which covers the spermatic cord. We have three coverings: external spermatic fascia, cremastic fascia, and internal spermatic fascia. Okay, so these are the coverings of spermatic cord. Round ligament of uterus, they have just put round ligament of uterus. Yes, it is a complete content. But ilioinguinal nerve, as I told you, it is a partial content. Why it is a partial content? Because it does not travel to the entirety of the canal. Okay, it pierces the internal oblique muscle, enters the canal in the halfway and reaches the superficial inguinal ring to reach the scrotum. Clear? So, the ilioinguinal nerve is a partial content and it does not extend from the deep inguinal ring. Okay, it extends midway in the inguinal canal by piercing the internal oblique muscle. Okay, so as I told you, ilioinguinal nerve is a partial content. It enters the canal by piercing the internal oblique 2.5 cm below and medial to the anterior superior iliac spine. So just remember, this is a partial content, it is not a complete content. Next important question, which structure is not damaged during vasectomy procedure? Okay, so now we are talking about when they do a vasectomy procedure, they will handle spermatic cord and they will ligate, they will make a loop, okay, in such a way that the spermatic cord is looped so that there is no continuity of the canal of the spermatic cord. Okay, they make a loop. Okay, so they will be handling the spermatic cord. Now, which structure is not damaged during vasectomy procedure? A, ilioinguinal nerve. B, nerve to testis or testicular nerve. C, cremastic artery. D, genital branch of genitofemoral nerve. Now, if you look over this particular choices here, now once again apply the what I have told you. So there are two important things comes into the inguinal canal. One is the spermatic cord, another one is the ilioinguinal nerve. So whenever the surgeons are handling the spermatic cord, they make sure not to injure the ilioinguinal nerve. They identify the nerve because it is a separate content and they isolate the nerve from the spermatic cord. So when you open the spermatic cord, the external spermatic fascia, the internal spermatic fascia and the cremastic fascia, we get these content, the testicular nerve, the nerve to testis, the artery to cremaster, and of course the genital branch of genitofemoral nerve. It also forms a content of the spermatic cord. Okay, so the structure which is not likely to be damaged during vasectomy procedure will be ilioinguinal nerve because it is a content which is not present inside the spermatic cord, which is present outside the spermatic cord. That is why it is not injured. Next important question asked somewhere 4 or 5 years before. What is called a triangle of doom and it is bounded by all except. Okay, so I want to understand what is the concept behind this triangle of doom. Nowhere asked, I believe one question was asked in one of your competitive exam. Okay, now please look at this picture and take some time in understanding. Okay, there are 3 important triangles given there. One is a Hazelbach triangle, which I have already told you. And when you look down there, you look at something called the triangle of doom. And also there's something called triangle of pain. But let us focus on this triangle of doom. Okay, and why it is called the doom? Because the content here will be the external iliac artery and the external iliac vein. The external iliac artery and external iliac vein. So these are the major content, important vascular content of this triangle of doom. Clear? So which means what? When this particular area is injured, when the artery is ruptured, the patient is doomed. That is why it is called triangle of doom. Okay, so look over the boundaries of the triangle of doom. We can see this beautiful vast difference. Can you see that? With the spermatic cord, entering through the deep ring, okay, and you can see the gonadal vessels going there. The apex will be formed by the deep ring here. Can you see the apex? So this is a triangle there. This is a triangle. Apex will be by the deep ring, okay, medially by the spermatic cord, laterally by the gonadal vessels, and base will be by the inguinal ligament. Base will be by the inguinal ligament, and of course, the content of this triangle of doom will be the external iliac artery and the external iliac vein. Okay, let us go into the triangle of doom is bounded by all except a vas difference. Yes, the vas difference from the medial relationship, okay, as it enters the deep inguinal ring. So vas difference from the medial boundary. The gonadal vessels forms the lateral boundary, okay. The gonadal artery and the gonadal vein forms the lateral boundary, and the base will be by the inguinal ligament. Apex will be by the deep inguinal ring. So we have the gonadal vessels here, which forms the lateral boundary, medially by the vas difference and base by the inguinal ligament, and the content will be the external iliac artery and the external iliac vein. Yeah. So the answer out of odd man out, the Cooper's ligament, that is an odd man out. Okay. So you have to just know what is called a triangle of doom. Okay, and you should know the boundaries of the triangle of doom and of course the content of the triangle of doom. Okay, and when you look at the picture once again, when you go laterally, there is something called triangle of pain present there. Can you see that? Triangle of pain. Why it is called triangle of pain? Because there is an important nerve traversing there. This nerve is called the genital branch of genitofemoral nerve, and its counterpart, the femoral branch of genitofemoral nerve. So this genitofemoral nerve has got two components, the femoral part, the genital part. Okay, so the genital part enters the spermatic cord and goes inside the spermatic cord to supply the sensation over the scrotum in males and for clitoris in females. And its counterpart, the femoral branch of genitofemoral nerve, travels laterally in that particular area called triangle of pain. So when that particular thing is endured during laparoscopic procedures, right, pain, meralgia sensation, or even sometimes parasitic sensation will be present there. So that is why it is called triangle of pain. Okay, so the three important triangles you should know about when you talk about the inguinal canal. One is the Eiselbach triangle, which is an absolute necessary you have to know. You have to know about something called triangle of doom and triangle of pain, and at least you should know the content of the triangle of doom and the triangle of pain. And the important content of the triangle of doom will be the external iliac artery and the external iliac vein. Thank you so much for listening to this class. They say inguinal canal is an odyssey. It's a very big topic to be explored and to understand, because how many times you read, the boundaries may sometimes confuse you, because it is not, when you look at it in a 3D picture, you will understand it much better. But when you look at in dissection, no, we dissect layer by layer by layer, and the inguinal canal will be much exposed, so that you won't see much of the text, whatever we study in direct dissection. I believe that today you have understood the concept of inguinal canal, how it is formed, the boundaries, the content of the inguinal canal, and how we apply clinically to case scenario in case of an inguinal hernia, and how we divide the hernia into direct and inguinal hernia and indirect inguinal hernia, and what is called Eiselbach triangle, and all other facts. Thank you so much.